If you're a driven, active person who wants to reach and pursue a higher quality life with some ambition, then guess what? This podcast is for you. This is the Driven Athlete Podcast. What's up, y'all? It's your man, Dr. Kyle, Driven Athlete Podcast. Welcome back. Appreciate y'all coming in to listen. We got a controversial topic today. All right, pain science and the pain experience. Okay, pain, because it's interpreted different ways, right? In different cultures, interpreted different ways, in different people, different walks of life, different stages of life, interpreted different ways. But I want to start this off real controversial, okay, and thought-provoking. A quote by Lil Wayne, the rapper, okay? Pain is an opinion, which is totally true, all right? Pain ultimately is an output. Pain is not an input, okay? A person's body parts are not alive, right? They're inanimate, right? The only actual aware and conscious organ in our body is our brain, right? So if somebody's battling pain in their knee, their ankle, their back, their neck, those body parts don't tell you they're hurting. They just send signals, and those signals are sent and received and assessed, synthesized, broken down, and then a judgment is made. And then therefore pain is generated and produced by the brain, all right? So pain is 100% generated by the brain. It's produced by the brain, okay? Body parts and nerves don't tell you they're hurting. They send signals, totally, and they're very good at sending signals. We know that. Okay, there's a deep, intricate connections, a matrix between all of your body parts and nerves and your central nervous system through your spinal cord, the brainstem, the brain, totally. But to be clear, pain is an output, and your body parts don't tell you they're hurting. And it's just interesting. And once those signals and everything is assessed and assimilated and synthesized, then the judgment's made, and it's like, yep, this is causing pain, right? And that we would call that the pain experience versus just the better term is pain experience, not just pain, because it's like a lot of things come with it together. And we're going to deep dive into this, okay? So it's just interesting, okay? And we're going to dive into some psychology stuff. That's not my thing. I'm not smart enough for that. All right. I'm a sports physical therapist. Biomechanics and pain is what I do. Right. But we can't neglect that there is a psychological and emotional component with pain, and we can't separate the mind from the body. All right. We can't separate the mind from the body. So we can't separate nerves from all of our other body parts, like our muscles, tendons, bones, ligaments, visceral organs, all those things. Totally. Nerves are definitely connected, and we can't neglect that. And they're also connected to your central nervous system very intricately and delicately. And we can't separate the mind from the body ultimately. All right. And this is but what I was going to say is those signals that are being relayed and sent from your sensory organs, which are your nerves, they're just signals. They're danger signals or other positive signals, but they're just signaling. And those signalings are then sent and assessed and interpreted in the brain. All right. And imagine if somebody was in pain for a long time. Okay, this is where it gets deeper and a little more controversial, or just thought-provoking. If someone's in chronic pain and they've been in pain for years, right? Past 3 months is when you would consider something chronic versus subacute and acute. Acute pain is like when something flat happens right away and you're in pain. And if it continues to linger past 10 to 12 weeks or 3 months, then it usually jumps into a category called chronic pain, right? Or persistent pain, right? We'll call it chronic pain. So acute pain is at the very early stages. Subacute pain is when it's still lingering. And then chronic pain is when it crosses over 3 months and beyond. And for scientists and physicians and surgeons and stuff, physical therapists, chiros, like all the healthcare practitioners, when somebody's in pain for longer than that, it questions like, how? That doesn't make any sense. As in, tissues and joints and damaged tissues heal really well. Like the body is really good at healing itself, right? Everything heals usually within 6 to 8 weeks. So from a soft tissue standpoint, muscle tears, ligamentous injuries, joint capsule injuries, musculotendinous junction strains, spraining an ankle, all those things, right? tissues heal in 6 to 8 weeks. That's the turnover rate. Somebody's regularly healthy, right? Not like an autoimmune thing that's blocking systemic healing processes, all right? Bones usually take 10 to 12 weeks to heal. All right. So like if someone has a fracture, that's why usually people are in a cast for 6 to 8 weeks and then they're out and they can gradually perform activity, physical therapy stuff to get that facilitates healing process. But bones usually union and heal and ossify in 10 to 12 weeks. It's only 12 weeks. That's 3 months. So if somebody's battling pain longer than that, let's say 10 years, 5 years, like even just a year, 6 months, it's like everything's healed at this point. Then why are they still battling pain? We can't neglect there's nerves also. All right, we're going to deep dive into that. All right, so this is a controversial thing we talk about with our patients for sure. It's a very tactful and delicate dance of a conversation. So if somebody is battling pain for 6 months to a year to 5 years and it's not going away and it's worse, like this is usually how the conversation goes with us. All right. So, and we just are here to help people, right? We're not here to change someone's emotional states or we're not psychologists, and we stay in our lane totally. But we can't neglect that we can't separate the mind from the body, and also that nerves are involved. So here's what the conversation usually goes like. All right. So Mrs. Jones, whatever, right? You have neck pain that's been going on for a long time, right? We got muscles, you got ligaments, you got tendons, you got joints, bones, all those things in your neck for sure, or your low back, whatever. But we can't neglect, we also have nerves. And nerves innervate and are very sensitive, and they detect danger signals, and they're very good at that, right? And nerves of anything take the longest to heal, okay? So muscles, bone, tendons, ligaments, all those things, they take time to heal for sure. Nerves also take a long time to heal. And if anything, actually, they take the longest to heal. So considering that, they're very sensitive, they're very resentful, they hold grudges, they have a great memory, okay? And when a person is in pain for a long time, those nerves, connections, and receptors aren't functioning as appropriately as they did in the past, and nor are they regulated or deregulated as appropriately as they were in the past. And they get used to sending signals. So we would call that like hypervigilance. Right? So if nerves are very hypervigilant, they're ready to send signals whenever. So, right, so they're on high alert, like a car radio on full blast, and they're ready to send signals. And the receptors of those signals are ready to receive signals. They're ready to catch anything they need to protect, right? So there's a lot of hypervigilance that can go on over time. So those nerves don't function as appropriately as they did in the past, and they send signals, and they're ready to send signals at a high intensity level, like a car radio on full blast for a long time too. So they're ready to send danger signals, real threats or perceived threats. Okay. Even just perceived tissue damage, right? If it's maybe not actual tissue damage present, they're still ready to send signals with perceived tissue damage or injury. So like the car radio on full blast, all we got to do is just turn the car radio volume down. Let's just turn the volume down, all right? And the best way to do that is movement and blood flow. The key is non-painful, non-aggravating, non-irritating, non-threatening movement to help deliver blood flow to your muscles, ligaments, joints, bones, all those things, but also to your nerves, because nerves need blood flow just like anything else. They need nutrients and oxygen just like every other tissue does in your body, and they need to heal. They just take the longest to heal. The movement and blood flow also helps to acclimate nerves to movement again. So we can shift their awareness and perspective of movement being a threat, but maybe more as a benefit. Because ultimately they will heal. It just takes time, right? Blood flow and movement in a non-painful, irritating way helps deliver nutrients, oxygen, helps acclimate nerves to movement again and get accustomed to movement again. And it deregulates their hypervigilance and turn the car radio volume down over a long enough time horizon. And I'm going to do everything I can to help. That's usually what the conversation looks like. All right, exit conversation. That's usually what happens. Then we can show some exercises that are appropriate and we course correct as necessary. But anyway, that's usually the conversation. We just try to help educate and shed light that, hey, we also have nerves that generate signaling and can allow for chronic persistent pain to occur, right? And we can't neglect that. We also can't neglect that there is a psychological component, right? And we can't separate the mind from the body no matter how hard we try. We can't separate the mind from the body, and that also plays a role too. Right? So I'm going to do everything I can to help and get things feeling better. Okay. We're going to be on the same team. That's usually what the conversation looks like. So the psychological component, if we're going to deep dive, or we don't include these next topics in our conversation, top points, This is just because I think this is interesting. I think it's an interesting physiology of the human body and the pain experience in general. And I'm just appreciative and glad that I've been exposed to these kind of things from mentors and other wise people smarter than me, right? And I've tried to deep dive into some of the research and things to help people. And then also take it on for my own personal experiences and my family and stuff. But anyway, I'm just glad I have these awareness and exposure to these knowledge stuff that researchers have found. So this is what we don't include in our conversations. I just think it's interesting. But ultimately, our perspective and beliefs shape our world. That's it. Like, perspectives and beliefs shape our world and how we perceive, the lens in which we view the world and the frame in which we perceive things. And that then dictates our experience, perception of things as they come to us. And it frames our experiences, our interpretations of those experiences. And then after that, what action steps and how we handle those experiences. Right? How emotionally do we manage and handle those experiences that present to us? And then what action steps do we do next? How do we treat people around us based on those experiences and how we manage our emotions based on that stuff? So our perspectives and beliefs shape our world. We can't, we can't neglect that. So from what I've heard of mentors and stuff and other experts, this is not my field, right? I'm not a psychologist. I just think this stuff's interesting, right? So join me in this discussion if you like. But some experts and mentors would suggest that those perspectives and beliefs which shape the way we interpret experiences ultimately all root back from our childhood of experiences we've had in those fragile, malleable times in our life when we're extremely able to be influenced. We're super easily influenced as a child, right? We're not exactly emotionally resilient as kids. That's why everything seems to be so traumatic, right? Otherwise it wouldn't make sense, right? Like we're young, undeveloped, emotionally, not exactly resilient, mature individuals until we're like late 20s. So everything that happens would be emotionally traumatic as a kid, right? So everything's just, imagine if some things that were traumatic as a kid for you, if when you're a grown, coherent, intelligent adult happened, it wouldn't be that big of a deal, right? But it was a big deal when you were a kid. Makes total sense. So for all the way back rooting from childhood that these mentors suggest, that ultimately from those childhood experiences shape our perspective and beliefs into adolescence and then early adulthood and into adulthood. So with that being said, that can influence maybe how as adults we experience pain. And our familiarity with it, our nervousness with it, and our fear associated with pain and our experience. All right. So to be clear, though, pain is real, right? We're not saying it's real for every time for every person. I'm not saying anybody's making it up. Like, it is a real thing, right? Very similar of like, hey, on a scale of 0 to 10, how much pain are you in right now? And somebody says an 8. Nobody has the right or ability to be like, no, you know what? You look like you're at a 4 out of 10 pain, not 8 out of 10 if I had to look at you. The same way somebody be like, how happy are you? I'm like an 8 out of 10 happiness. No, you're not. You're like a 6 out of 10 happiness or maybe a 5. I was like, how would you know that? You can't tell me how I'm feeling. You know what I'm saying? So it's a very similar thing. Happiness, pain, like what level 0 to 10 are you at? It is real for everybody, right? So it is a real experience. It can, whether that pain experience is present, whether there's actual tissue damage present or no tissue damage present. It's just interesting. I'm just throwing it out there. All right. So perceived damage or real damage, pain can still be present. Physical damage in your tissues. And this is where it gets controversial because perceived pain from perceived tissue damage or injury, perceived injury is still a real pain experience, whether or not actual tissue damage is present or body injury is present. So it's just interesting to think about. All right. So chronic pain on that boat is a whole separate animal within this pain science realm. And once a pain experience persists past 3 months, we consider it chronic. And somebody that's in chronic, long-standing pain, a thought that goes across that we find, right, and researchers find, they think there must still be something wrong. If I'm still in pain, there must still be something wrong in my body with injury and tissue damage, right? Something's not healed. There's something still lingering that's not healed yet. But we just discussed, though, in the science, cell turnover rate and collagen fiber healing times is actually 6 to 8 weeks, right, for soft tissue. And then osseous bone structures heal in 10 to 12 weeks. Right? I'm talking about like someone is somewhat normally healthy, right? They don't have an autoimmune, like a rheumatoid dysfunction or some other systemic pathology that would limit their healing potential. People usually heal in 6 to 8 weeks for soft tissue and 10 to 12 for osseous bone structures. So if someone's in pain for 5 years that's still lingering, their thought is, well, there still must be something still damaged, right? Like something's still wrong. There has to be. But the things heal within 6 to 8 weeks, or 12, maybe at the max. So if pain's been going for 5 years, then what happened the remaining 4.5 years of time after things got healed? Why is pain persisting? Right? The only answer, and what the researchers are finding, not me, I'm just relaying information. The neural structures are still hypervigilant and ready to send danger signals. When they're used to sending signals, they're still ready at a hypervigilant, elevated, regulated state of sending danger signals. And those danger signals are received by heightened vigilant receptors to receive those danger signals. And then those signals are interpreted, assessed, and assimilated. And then a judgment is made, an output of pain from the brain. Right. So it's just interesting. We don't have these conversations with patients because there's no benefit. That's not the route we go to help people. But as just a interested person in physiology and science, like I think it's just interesting. Right. That's what I'm sharing with y'all. But that has to be the answer, right? Because there's no damage. Very often people will get an MRI and imaging and stuff, which we're going to get in a second. Right. Imaging is very important and helpful total in decision making. But when something's been persisting for 5 years and they get a fifth MRI and it's like something still hasn't been wrong and they've already had 3 surgeries or whatever, right? Which is unfortunate. I don't hate surgery. It's not always necessary. I'm just saying. But MRI is finding slight abnormalities in their spine or their shoulder, rotator cuff, or their neck, whatever, their low back. And it's like, oh, I see it. There it is. There's a small abnormality, right? But it's not like glaring. And then it has surgeons stumped, as in like, you shouldn't be in as much pain as what you're describing. This doesn't look like you would expect on the image and what the pain output is, right? So with that being said, then our approach and talking points and direction of treatment is going to be different than our approach in a different situation, right? So with the pain science kind of step of direction and understanding, it just dictates maybe our direction of treatment and approach to help people, right? Because we want to help people, improve quality of life, totally. And it's going to be different with different people, and our talking points are going to be different. So anyway, people get really hung up on their imaging abnormalities, where structure of the image and structural abnormalities in a person's spine or shoulder or joints or whatever doesn't correlate to physical symptoms. So the structural abnormalities don't seem to correlate to physical symptoms. As an example, there's plenty of people that have an image that comes back not great, like it looks bad on their back. Their spine, they have arthritic changes, degenerative changes, foraminal space narrowing, stenosis changes, ligamentum flavum inflammation, herniated discs pushing posteriorly to the thecal sac and impinging on a nerve root at multiple levels, and herniated sequestered discs, right? Like, looks bad. And the doc says, you should be in more pain than you are. I would never say that, but like that's a message I hear a lot. It's like, your back looks like an 80-year-old's back. You should be in more pain than what you're describing. This is remarkable, right? And then they leave feeling worse than they went in. But anyway, those type of people, right? They have like mild back pain and they get an image, and that's what it comes back as. And like, well, I feel okay though. I don't have any radiating pain down my leg. I don't have any shooting pain. I feel just stiff, just soreness occasionally, right? And then you have people who have a pretty good looking image, maybe a mild bulge, but like nothing glaring. And they have severe pain radiating down their leg, and it's like lingers and it nags and it's like unrelenting and it hurts really bad. And they have radiating referred pain or sciatica pain, radiculopathy pain, nerve pain down their leg. And they're in severe back pain with spasms and stuff, but their image looks pretty good. So you have somebody with like a really bad looking image and they're in mild pain. Like, I feel fine. And they have somebody with a really good looking image and they have severe pain. So there's a disconnect between like the image and the structure and someone's pain and their symptoms. So then with that being said, is the actual structure the actual pain generator? Research might suggest no. I'm just saying, right? It can be totally, like tissue damage happens and it hurts, right? For sure. And the pain experience is real for everybody. But what I'm saying is if the structure and the disconnect between imaging and their symptoms and their pain prognosis and their functionality level and their direction of improvements isn't correlated to their structure on their imaging and their MRI and stuff, then should the structure be the focus of treatment, or should something else be? Or maybe a different approach and a different perspective on maybe how to improve someone's pain, right? And functionality. Maybe the structure isn't the sole focus. If it was, then why not just get a discectomy, debridement, and spine laminectomy surgery for everybody? right? If at some point 80% of people have back pain when they grow up and be an adult, then why aren't 80% of people just getting discectomies? Problem solved, right? Just fix the structure, right? The research has suggested it's not really the case, right? Because there's plenty of people that get surgery and they feel worse when they come out, or they pain on the other side of their leg or their back or whatever, right? I don't hate surgery. I think it's totally necessary sometimes. I think it's also important to realize and recognize that the structure and the herniated disc or the arthritic changes that are noticed and foraminal narrowing of the space, nerve impingement, evidence on an image might not actually be the pain generator. So is the structure the focus to fix pain? I'm just saying potentially not. And that's what the research suggests. Probably not. But anyway, so and to further that point, all right, I got some studies here. New England Journal of Medicine study, they found a high prevalence of abnormalities in the lumbar spine on an MRI exam of people without back pain. Without back pain, they found a bunch of abnormalities. Only 36% of those examined had a normal disc at all levels. Only 30, that means that, what is that? 64% of people had abnormalities. Only 36% had normal disc levels. And about half of them had a bulge at least at one intervertebral disc, and a quarter had at least one disc protrusion. That's not really that. I mean, that's a lot, what I'm saying, but that's not a lot of people that had pain associated with it. So 64% of people had abnormalities of a disc herniation or something going on, intervertebral disc issues and narrowing of space, whatever, right? But not that many actually had symptoms. It's just interesting. Systematic review of 2,100 patients without hip pain on an MRI, 2,100% of people, no hip pain. They found 37% of those people had a cam deformity, 67% had a pincer deformity, and 68% had labrum deformity. This is interesting. A cam impingement or cam deformity is a femoral overgrowth of the osseous, the bone structure, like hip impingement. Femoral acetabular impingement, FAI. Femoral acetabular impingement. So the femur can overgrow and then cause an impingement mechanism at the hip joint. The pelvic structure or your acetabulum can also have an overgrowth, and that can cause an impingement mechanism in your hip joint. So what they're describing is 37% of people had femoral overgrowth that you would think would cause impingement. But none of these people had pain in this study. 67% of people had a pincer deformity or overgrowth of the acetabulum or the pelvic bone attachment. 67% of people had this overgrowth that would suggest impingement in their hip, but nobody had hip pain in this study. And then 68% of people had labrum involvement or labral deformity, but nobody had pain. It's just interesting. The symptoms don't correlate with the actual structural deformity. So is the structure the problem? Again, probably not. Systematic review, again, 1,100 people of a lumbar spine MRI, ages between 20 and 70 years old, okay? 87% of those people had bulges. I'm sure a lot of them had in the later stages of life, like the upper end of those age, which we'll get into in a second. 87% of people had evidence of disc bulges, of people across the board from 20 to 70. But do you see 87% of people rolling around and hobbled over in back pain? No. Another systematic review of 3,100 patients on an MRI, 3,100 people on MRI of a lumbar spine. 37% of 20-year-olds had evidence of disc degeneration already. 96% of people at the age of 80 had evidence of disc degeneration. 37% at 20 years old. That's you would expect a lot, but you don't see like 37% of 20-year-olds hobbling around in back pain with referred nerve pain down their leg. I'm just saying there's a disconnect between structure findings on an image and the abnormalities of their spine structure and actual symptoms. All right. Okay, another study, 70% of people over the age of 43 have some kind of abnormalities found on an MRI of their lumbar spine. 70% of people over the age of 43 have some kind of abnormality, but you don't see 70% of people at 43 or above hobbled over in back pain or getting discectomies and surgery and stuff. Like, I have severe back pain, right? I mean, pain comes and goes, totally can go away, and we're going to do that in a second too. But that just, again, furthers the argument that structural abnormalities don't correlate and dictate pain, symptoms, or functionality or prognosis forward. I'm just saying. So with that being said, is the structure the focus? Right? Just saying. So it's interesting. I had this conversation with patients. The nerve hypervigilance discussion of like, we can't neglect there's nerves in there too, and they can send signals. We got to turn the car radio volume down. That's it, right? And also, by the way, to bring hope and make you feel better, like 70% of people over the age of 43 have some kind of disc or a lumbar spine abnormality or cervical spine abnormality, right? But not all of them have pain. So maybe the structure isn't really the problem, right? I'm just saying, so we can work around stuff appropriately and get you back to feeling better. And after 20 minutes of a conversation, the patient will be like, okay, cool, yeah. So, but what about my herniated disc? I have a herniated disc. You see it on MRI. I'm like, oh my gosh, did you not just listen to the 20-minute conversation we just had? Everybody has herniated discs. It's not that big of a deal, right? It doesn't have to be unless you want it to be, or if you don't want it to be. Controversial statement, I'm just saying. I don't say it to patients, but what I'm saying is like, everybody has herniated discs. Like, did you not just listen to the 20-minute conversation we just had, trying to minimize the structural abnormalities that might freak people out, right? I don't hate MRIs, right, or imaging, but it can be really helpful. It can also set the stage for people to ruminate and hang their hat on imaging that they find of like, but I have 2 herniated discs. Like, yes, we know. Everybody does, right? I'm sure I do too. I played football and volleyball in college. Like, it doesn't dictate or correlate symptoms. Anyway, all right. So as mentioned earlier in this discussion, when somebody is experiencing pain for a long time, the intricate nerves and connections don't function as appropriately as they had in the past, and they're used to sending signals and are just high alert, hypervigilant, ready to send signals to protect from danger, real or perceived danger. Danger might actually be present, but signals are still being sent. And then an output of pain is presented, and that experience of pain is occurring, right? So it can still be real pain. You just got to identify where's it coming from. So like I said, the best way to intervene, like how do we intervene? What approach should we do? Non-irritating movement and blood flow. Because just like any other structure in the human body, the nerves need blood flow. They need to reacclimate to movement. And the best way to deliver this capacity to heal and perceive movement as less of a threat and more as a benefit, get them more resilient and acclimated to movement again, is by moving and grooving around in a non-painful, aggressive way. Doing some exercises, right? Just things that don't cause more pain. Not just pain, but heightened more pain. Because people are always, in the past, I would catch myself because it'd be like, I would do the exercise. We taught this whole pain talk, I'd work with patients, be like, I want to get you feeling better, right? I was like, hey, is this causing pain? And the response is, I'm always in pain. So yes. And I'm like, what I should have asked is, you came in with a 6 out of 10 pain. We're doing these things right now. Is this making it more than a 6 out of 10 pain? Well, no, it's the same. Okay, perfect. So we're not making it worse. Success, a mission accomplished. Let's keep going as long as it's not making things worse. Because you came in at a baseline at 6 out of 10 pain, and this isn't making it worse. We're good. We're not making things worse. That's what we're not irritating or aggravating things more. That's the question we had to ask. And usually, depending on where they're at, they're like, well, okay. I was like, gotcha, right? But anyway, so that's the question we had to ask. So with all that being said, we have to acclimate nerves to movement again, perceive movement less as a threat and more as a benefit. And over time, the car radial volume will decrease and the regulation and hypervigilance will improve and re-regulate if a person wants it to. I'm just saying. I'm going to say something controversial. Not everyone wants to get better. And I didn't realize this until later in my career. And I had mentors kind of describe this to me. The radial volume of nerve hypervigilance and receptor hypervigilance and output intensity, that volume can decrease, and it should decrease if the patient wants to. That's a decision. That's a decision they have to make. Do they want to get better? Not everybody wants to get better. I'm not going to ask somebody, do you really want to get better, right? That's something we ask. We'll approach things maybe differently. It's not my job. I'm not a psychologist. I'm not a mental health expert, right? All I'm saying is like, not everyone wants to get better. And I have interesting stories about this that I've experienced with patients where I had mind bomb epiphanies about like, oh, this makes total sense. Oh my gosh. But if a person fully accepts that pain doesn't have to stay here forever, pain doesn't have to linger forever. It can get better if you want it to. Just a matter of making that decision. If you can fully accept that reality from a physiological standpoint, the key is avoiding super irritating things over time and movements that will heighten the sensitivity and heighten the hypervigilance of those innervated areas and neural pathways, which can be a slow process and seem like we're not really doing anything. It just takes time, and trust the process. And we'd be here to help you, right? Totally. I'm here to help. I'm on your team. So interesting story, right? Because this isn't my scope of practice with like the psychological component. And we can't neglect that with a pain experience, right? Which is an output from the brain as discussed. We can't separate the mind from the body. Physical pain doesn't only just come from physical structures and nerves. There's another source. There's an emotional component to pain. And there's a psychological component to pain that we can't neglect, right? We can't neglect. There is a psychological component to pain. And to further this argument more, imagine if somebody, just in general, right, is that fear and nervousness and a lack of familiarity with painful situations or a certain situation can heighten the experience and can heighten and intensify pain. Right. So if somebody is very nervous, like they have they've never played sports or something like that, they have an ankle sprain. Imagine if like an MMA fighter or a UFC guy gets punched in the face or gets his ankle rolled in a grappling grip, right? And he rolls his ankle. He's not writhing in pain. He's used to it. It's familiarity, right? The same tissue damage occurs as somebody that's never had that happen before, but the person has never happened before, they're in severe writhing pain. There's a fear associated, a lack of familiarity and nervousness associated with pain, and an experience that happens like, oh my gosh, did I just like ruin my ankle for my life? Imagine if you've rolled your ankle 15 times. By the fifth time, you're like, oh yeah, I mean, it's, it'd be swollen for a little while, but I'll get better, right? It'll be fine. That happens, right? And a perfect example is UFC fighters. There was a fight I was watching where it was two vets getting after it. They're expert fighters. It was on TV. Like I was just watching on TV. And this dude had this guy in an arm lock and broke his arm on camera. And you saw it snap, right? And it was just dangling. And the guy that has his arm broken sat up and looked at it and then shook with his other hand, shook the other guy's hand and said, hey, good fight, and his arm's dangling. He's just been used to it. Like it's not, imagine if somebody wouldn't be used to it and there's not as much fear associated with an injury, right? They'd be freaking out. They'd be writhing in pain and be like, oh my God, like, right? It's totally normal and expected, right? I'd be freaked out if my arm broke and never had it happen before. But someone who's a vet who's had injuries like that happen before, there's not as much fear at all. And he's used to that kind of pain or that kind of injury and familiar with like, I'll just get a surgery and get it fixed to be fine, right? It'll be in pain for a little while. It'll be swollen, but like, I'm not going to die, right? So with that argument, we can't neglect the emotional component and intensification of pain when other emotions are present and a lack of familiarity. So that being said, psychosomatic pain and emotional-based pain is real, right? It causes real physical symptoms, but what's the source of this pain? It's an emotional source. It's a psychological, psychosomatic source. And that over time can totally change and manifest physical changes that would be evident on blood work, immune system blood work, and other physical symptoms, right? Like arm pain, back pain, knee pain, leg pain, neck pain, shoulder pain, all that stuff. And this is where it gets really tricky and controversial and difficult, right? And this is where I lose people. If they want to have this conversation, I don't have this conversation with most people at all, right? It's just like, I just think it's interesting, right? And if you want to have on board this discussion, let's dive in, right? But anyway, so considering that emotional pain and physical pain output areas are located in the same region of the brain with the same circuitry. So the brain doesn't actually differentiate physical pain from emotional pain. It's the same area and the same circuitry and the same output area. So it's the same, it doesn't know the difference. It's just interesting. So it feels the same, right? So if you link physical pain with some emotional influence attached to it, that allows things to linger for a long time and not get better. That leaves objective healthcare professionals stumped, right? And all they do is like, I just want to help. Right? How can let's look at the image. Let's look at your joint. Like what's wrong? Why are you having pain still? Let's look at this MRI. Well, you do have a mild we fixed it with a herniated disc discectomy and a disc replacement or a foraminotomy. Oh my gosh, foraminotomy and a laminectomy. That doesn't make sense why you're still in so much pain. Maybe I missed this area. Let's look at it, right? So a person that doesn't have this kind of a thought, awareness, consciousness of like this pain experience thoughts, physiology, they're like, yeah, there must be something wrong in there still. So from a surgeon standpoint, they're like, okay, how do we fix it? We got to go in there and do surgery again, right? Or maybe an injection or just pain meds, right? Just saying there might be another source that's contributing and heightening, intensifying this lingering pain. That's not my job, not my role, not my lane. This is interesting to me. I'm just bringing it up as a conversation point. So with that being said, these topics of discussions, I think it's just interesting, and I'm glad I have my own awareness of this stuff. So physical pain that roots from a emotional or psychological component can still manifest physical changes and cause real pain experiences, and also manifest hard, objective physical changes like systemic dysfunction, immune dysfunction, blood work tests that come back abnormal of like your white blood cell count's way down, right? Or your platelets are way down, right? Or these hormonal regulation lab values are way off. Like your testosterone is way down. What does that come from? It can definitely be a gland problem, but let's say somebody otherwise was normally healthy 8 years ago, and then all of a sudden they're still healthy and otherwise healthy, right? And that's like a systemic pathology of like cancer or autoimmune disorder, and all of a sudden nothing's changed, but their testosterone's dropped. Physical manifestation and blood work values can change from emotional and psychological sources, and that's a fact, right? Like it is what it is. Can we accept the reality of that? And if that's the case, then what's the route to fix the problem? Would a physical, structural, surgical intervention fix that? No. And it's not my job either. But if that's the case, and if it's an emotional, psychological source, then we got to fix the emotional, psychological issue. And that would be like a mental health professional, right? That's not me. And number one would just be accepting and realizing like, oh snap, I am stressed, whatever's the case. I'm not going to get into that. That's not my thing. But anyway, it can totally be a huge link to abnormal manifest objective findings physically and physical pain. And at this point, this is where people are left in limbo, where they don't have any closure of an answer of like, then what's my diagnosis? What's the problem? What's my diagnosis, right? I have these hormonal values that are abnormal and outside the norm range. And I have these immune system lab values are out of normal range. And I have these other values that are abnormal range, and my back hurts, and my foot hurts, and my shoulder hurts, and my neck hurts. I'm just saying that's where people left in limbo, and they're like, I don't have any closure. What's the diagnosis here? Like, what is my problem? How can I fix it? Right. And then from a healthcare objective standpoint, that's where docs, right, who want to help totally, and they're super smart, or physical therapists who want to help. And I think I'm smart. I want to be smart in my field. That's where like, what can we do to help? Well, you're lacking these hormonal values. Here's a medicine that helps fix that and regulates it. You're lacking these hormonal values. Here's another medicine. You're lacking these immune system cell values, and they're low or high or whatever. Here's a medicine that can fix that. Is that really going to be a long-term solution, or actually addressing the source of the problem? Maybe not. So anyway, with that being said, I've seen a plethora of patients in this boat. It's not my job to dive into the psychological or emotional aspects. It's not what I do, and I wouldn't go into that. But we think that maybe that's contributing, and that could be contributing to what's creating these physical abnormalities, and nobody has an answer, right? But is somebody willing to accept that pain can come from an emotional, psychological source, and then after that, then take action steps? What concrete actions can be done? So I've heard some experts suggest, and this is like the biopsychosocial model of healthcare: biology, psychological, and social, biopsychosocial approach versus a pathoanatomical pathology of your anatomy. There's an issue with the structure, like where's the source of pain or dysfunction, right? So I've heard some experts suggest social support, family dynamics, perspective and beliefs that shape their world, which started being shaped from childhood trauma, where mental health experts would want to dive in. That's where they would approach and start. What's your family dynamics, your social support structure look like? Right? They would start asking questions like, what's your relationship with your dad? What does that have to do with my back pain? I'm just saying. Childhood, like, and some other expert would say that like And I'm not me. This is what another person said, but I don't disagree fully. I don't know. All pain eventually can root back to some kind of childhood trauma or childhood dysfunction. Current family dynamics, current family support, current social support, and current perspective and beliefs can also affect and intensify and enable lingering chronic pain. And one of those could be spouse resentment, right? I heard another expert suggest that 71% of someone's perceived happiness is directly correlated to their relationship with their spouse. So family dynamics and their spouse marriage dynamics, right? It's just interesting to me. I just be like, oh, okay, I take for what it is. I'm not going to dive into this with people, but like, it's just something to consider from my end and the approach and perspective belief that I have and the frame and lens of pain that I have my own life and people and my patients, right? Just dictates my approach to stuff. But anyway, spousal resentment can also be a huge part of that family dynamic that can enable and allow lingering chronic physical symptoms as it relates to mental, psychosomatic, emotional, and psychological based pain. So if the puzzle pieces aren't fitting in the right way and something doesn't smell right, that's just something that experts would suggest to dive into. I'm just saying. Continuing this conversation, all right, I got 6 pages of summary stuff I wanted to dive into with this, but it's just shedding a different light on maybe what the root cause of chronic pain. Because here's a story that I've heard before that is just very interesting, right? Like I've had a patient say this, and I've had multiple patients along the same lines. Guy comes in, this was a while back. I was back in Houston, but he was like, I'm here because my doc told me to be, but my back pain started in 1996. This at this time it was like 2016 or something. This is like 20 years prior, 20 years of back pain. He's like, yep, my pain started in 1996 when I helped my dad or my brother move out of his house, and I was lifting a table upstairs, and after that my back hurt. And it hasn't stopped hurting since then. So I'm like, in my head, in my early days, I'm like thinking very biomechanics, like, okay, maybe your thoracic spine isn't moving well. What's your hip range of motion? What about glute stability in your core? And like, we can work all these things, a manual therapy. What if I mobilize this and then we strengthen this and then we work on this balance and dynamic stability, and that will help your core, make your back feel better. And they weren't getting better. And they would come back the next day next week, and I'd be like, all right, so how you feel? Did you do your exercises? Did you do this? He's like, yeah, I did all of them. That hurts worse. And I'm like, oh man, we got to change direction. Maybe I was wrong. Let me call my mentor on biomechanics and like do this and maybe this, and maybe I should do this instead, and these exercises and this manual therapy and this soft tissue work, whatever. Maybe this is the structure that's making issues. And he came back again. He's like, yeah, it hurts. It's not getting better. And I'm like, we always get people better. Like, what? I don't understand. How is this not helping? Anyway, I'm bringing us one of my mentors, and they're like, yeah, did you have the pain talk with him? And I'm like, no, I didn't. I didn't even consider it. Like, it wasn't even the thing yet. You know what I mean? Like pain science, right? I'm not going to get into his family dynamics. It's not my thing. But like, as in, hey, we know that nerves contribute to signaling if danger and physical tissue damage is present or not. And we just got to get like a car radio on full blast. We got to decrease the intensification of that car volume, right? The radio volume, and just decrease pain, or to decrease the neural hypervigilance and ready to send signals, right? And then have those nerves be aware that movement could be a benefit, not threatening. And the best way to do that is just movement and blood flow, right? Anyway, I was just like mind blown. I was like, oh, of course. Had another guy that he was probably in his early 60s, maybe late 50s. I want to say late 50s. And he had been battling chronic back pain, right? Same situation, same time frame. He's like, yeah, my pain began in 10 years ago doing this. And I was lifting these items at my job, and since then it hasn't gotten better. I'm like, oh man, okay, well, let's work on this and these mobilizations, and maybe your back is contributing this way, and then maybe your hips. So what about your ankles? We can look at your ankles for squats, and then your core stability and glutes and whatever. And we were doing all these things, and he's like, yeah, I feel all right. I was like, okay, great, we're not worse. He's like, no, perfect. Okay, do your homework. Do this, this, and this. I'll see you next week. He comes back, and I was like, all right, so how'd it go? How do you feel? And he's like, yeah, I feel worse. I was like, did you do exercises? Like, I did some of them, but they always hurt. And I'm like, they always hurt. well, let's do this then. We'll work on this, this, and this. And we do these interventions and I'll work on that. And he's like, okay, yep. And I'll do your homework and I'll come back next week. Came back and I was like, all right, how you feel? Like I was brainstorming. I was researching all these articles on like what I can do to help. And he's like, yeah, it still hurts. Doesn't feel better. Actually might feel worse. And I'm like, what? I was like, maybe we got to work on that. And cause I think this can help. And he paused, he looked at me and he goes out, Kyle, I've been in pain for 10 years and I'm not going to get better. And I was like, what? Like you can? Like there's no reason why. He's like, I'm not going to get better. And I was like, oh, I was like, why? And he's like, I've been in pain for long enough and I'm not going to get better. I was like, what'd you like? And I was like, then I've dropped it. Later that day, I was asking him questions. I was like, so how, like later in the session, how was your weekend though? Like hanging out with your wife or whatever, and like your kids. And he's like, yeah, I just did some yard work and I was lifting these bricks. And I'm like, you're doing yard work and lifting bricks. I was like, but you're never going to get better. And he's like, yeah. And I was like, oh, you got your back pain originally from working on the job and there's a litigation involved and you have to submit disability insurance evidence and proof this week. And if he gets approved, he gets life disability checks. And I was like, oh my gosh, not everybody wants to get better. Right? This individual was willing to just be subjectively report he's in pain and not be functional and not do things that he wants to do. There was a financial incentive involved. And I was like, oh my gosh, totally true. So anyway, I was like, not everybody wants to get better. On the same note, there's another patient story that I've come across with that some people just don't want to get better, right? I didn't know, I wasn't diving into this stuff, but this patient who was a high level in the law space. Okay. This was a couple years ago too. And she had been battling neck pain and arm pain and mid back pain for like years. And it's been getting worse, right? And it's not getting better. Imaging came back with some mild abnormalities, but nothing alarming, like mild arthritic changes, right? That's not warranted to cause like severe back pain and radiating arm pain, right? It's like, this doesn't make sense. Why is this pain so severe and intense? But anyway, after talking, and I was mentioning nerves and like, nerves can be sensitive too. And we just got to get nerves to feel better and they acclimate the movement and blood flow can help. And we just got to deregulate the radio volume and I'll do everything I can to help settle things down because we can't neglect that there's also nerves in there that can generate pain, not just like muscles and tissues and herniated discs and your joints or whatever. Anyway, so we were talking more and she was just, her phone was ringing mid session and she was answering her phone and she was like yelling at her family on like some of her kids. And then her husband wasn't really helping in the situation. And she had been mentioning how she's, has all these doc visits and stuff. And I was like, oh my gosh, this makes total sense too. If she's always in pain, she's the center of her family's attention and she can be taken to all these doc visits. And her husband is toting her, up like always just pampering all the time. Like it's just a lot of support, right? Because he wants her to feel better and he feels bad. And then her doesn't have a great relationship with her daughters, her two daughters and like her one son or something like that. And like, I was like, oh my gosh, this makes total sense too. I'm not diving into that. I'm just my own brain in my own head. This is a while back, right? But like another patient or therapist told me very similar situations. And I'm like, I don't think they want to get better because if they do, that family support is removed and maybe they would be falling back and drifting into quicksand of irrelevance of their family, of their social support, whatever, that maybe when they were growing up as kids, which then again, she was described like we have conversations, like they just open up about stuff. This individual was describing like not the best childhood growing up either. And they were emotionally abused. I don't want to say physically abused. I don't really know the story, but there was a lot of turmoil in their childhood. So there's like that in the background of that shapes perspectives and beliefs and then current family dynamics. And there's a lot going on with their kids and her husband. And I was like, oh, not everybody wants to get better. It's just interesting, right? So it's just something to think. I just think it's interesting, and it's not my realm to dive into the mental health and emotional, psychological sources of pain, but they are real. And then eventually, it can cause and manifest physical symptoms and physical abnormalities and lab values, as an example. Right? It's just something to consider. I think it's really interesting. So, with all that being said, like it's not my job nor expertise to dive into that stuff, but people do open up and express feelings and their family dynamics and past experiences and things. That's interesting, and I respect it totally in full confidence. Like, I would never abuse that, but it's just something interesting that my approach will change, and then talking points will change, and my approach to helping them get better might change. But I also can't take it on myself to get really frustrated, because I used to, as in like, why aren't you getting better? I'm doing everything I can. I'm diving into the research. I'm calling mentors. I'm looking at articles. I'm reviewing my previous notes. I'm doing this manual therapy and course correcting and trying these exercises, and nothing's helping and you're not getting better. I'm getting very frustrated. Like, why can't I help? Right? But now I'm like, oh my gosh, not everybody, I'm going to do everything I can to help, but not everybody wants to get better. And there is a different source of pain that can generate physical symptoms. And I'm aware of that now. And I want to help everybody totally, but a little less self-defeating and frustration on myself, knowing that the pain experience sometimes is out of the physical biomechanics, symptoms, and control, right? And it's not my job to dive into the latter. But anyway, so we're doing everything we can to help. So it just changes the approach and how we do stuff, right? And a different light in which we can perceive and believe the way that pain comes and goes. And a person doesn't have to be in pain forever unless they decide to. Not everybody has, and I understand, not everybody has the capacity or the awareness to make that executive decision, because there's emotional and cognitive issues that can affect someone's awareness. Like, they're not a high functioning cognitive individual, right? It's if there's disability involved, right? Cognitive disability. But if somebody otherwise is not having cognitive disability, they don't have to be in pain forever unless they decide to. The first step is just accepting how pain actually really works. And if they got better, would that remove some incentives? I don't know. Financial support, emotional support, resentment. I'm not really sure. It's not my realm. I'm not going to dive into that. That's not what I do. But if they did get better, would that remove those incentives and comfort? I don't know. So it's not my job, and I can't control that stuff. I'm gonna do everything I can, but that's up to them. And all we can do, and I can do, and our, people that want to help in healthcare, is share insights from a neuromusculoskeletal standpoint to try to add benefit to people's lives and hopefully improve their quality of life. So that is what pain science is, and the pain science approach. And I think it's just really interesting, and these discussions I really enjoy, and diving into this stuff. And if y'all have any thoughts or questions or insights on this discussion, I'm always open to suggestions, comments, concerns, conflicting opinions. I know this is slightly controversial, but I'm open to conversation, right? So don't hesitate to reach out. And if you have any questions and pain that you feel like you've been battling that you want help with, we would love to chat and at least share some insights or put some mental effort towards helping you. And the best way to reach us is either a phone number at 561-899-8725 or our administrative email, team@athleterc.com. And check us out on Instagram, check out other podcasts. Feel free to share this one if to anybody you know. We're always open to helping more people and expanding our reach. So we'd love to hear from you guys, and we'll catch y'all next time.